May his soul rest in peace and also console the bereaved family. Now, to share his memories, we have with us Dr. Naik, who is one of his close associates. Over to Dr. Narayan Naik to share your memories about Dr. Omnan. Over to you.
Thank you, Dr. Shalu. It is really indeed a very sad day, the 4th of August this year. We lost a very senior colleague of ours who was very active in our association ever since we formed. Though he was not sort of volatile and this thing aggressive in talk and all that, but he was a very, very good person to do any job in our association. He, as Dr. Shalu said, he got his training. I mean, he is an anesthetist. He got his training in medicine from Calicut Medical College, and then subsequently anesthesia training from Kottayam Medical College, and joined the insurance services of the Kerala state, and retired as joint director of the state insurance services in 2000. And he was very active in our association and wanted to take all the social causes we played also. So the best thing I would say attributed to him in this regard is in the early 2000, means soon after our 99 conference, we had our palliative care as a theme in the conference. And then we thought we'll start one palliative care center in Cochin. We didn't have in Cochin anything like that. So we started, I think in 2001, we started, and he himself volunteered to be part of the thing. He himself get trained in the field. He went to Calicut and stayed for 5-6 months, studied how it should be run, and then he was running this center on our behalf for almost 2-3 years. This is the first center in Cochin. In Cochin, we started as a free service for the whole this thing, but unfortunately, because of the poor patronage, we had to discontinue in a couple of years. More than 2 years we ran, almost 3 years. But he was doing from morning to evening. He was there all the way, looking after all the this thing, interacting with the patients, whoever came. He was very helpful to the patients, and he ran a good name for us. But as I said, because of poor patronage, we had to abandon the process. In the meanwhile, other institutions started, so it became. Our departure did not make much of a dent. I'm happy that patients got services from other centers. And he, as Shalini said, he also became he was very actively involved in our association work. He became the president in the early 2000, and he was ever present till some years ago when his illnesses made him disappear from from the active this thing. He's survived by his wife Shantakumari and 2 children, 2 daughters, Lakshmi and Parvati. On my behalf as well as for the association as a whole, we express our deep condolences, heartfelt condolences to the bereaved family, and pray that his soul rests in peace. He gets moksha, as we all pray for in Hindu culture. We expect all of us to have moksha. That is ultimate. And then base of thought is the moksha. Thank you.
Thank you, Dr. Naik. So we all pray, may his soul rest in peace and the bereaved family be consoled. Now we move on to the scientific session. The scientific session is from Rajagiri Hospital, Department of Anesthesiology and Perioperative Medicine, Rajagiri Hospital. What we understand is the COVID situation didn't spare the hospital. They were rattled by rarities and lots of cases that they jolted them. So their team is here. Chairperson is Dr. Sachin George, consultant and head of the department. And a warm welcome to Sachin, chairperson. The topics which they have included: the stiff man nightmare, moderator Dr. Anto Paul, lead consultant neurosurgical anesthesia, case discussion by Namita Menon, resident. And the next is ROHAD. Now, what was that again? So moderated by Dr. Vivek T. Menancheri, lead consultant, surgical intensive care, and discussion by Dr. Deepak, a resident. And the third topic is never forget the parasite. Moderator is Shalini Ramakrishnan, lead consultant, transplant anesthesia, case discussion by Dr. S. Jayashankar, consultant anesthesiologist. So we expect to have a lively evening. Over to Sachin for chairing the session and subsequent procedures.
Before that, shall I interrupt 1 minute?
Yes, sure.
I see General MNG Nair, who is a friend of mine, who was closely associated with the starting of the Rajagiri Hospital. Yes.
I can't say no to Sachin. I know he was one of the strongest pillars of support for me in Rajagiri.
Yeah.
In the literal sense also.
So welcome you to our association and this meeting.
Thank you, sir. Thank you.
A very good evening to all. Thank you, Shalu Madam, Prema Madam, Office Bearers of ISA Kerala and Kochi chapters, and Nair Sir. It is a sweet surprise to see you here, and it feels great to be back in the midst of academics after a while. Now, rarities will rattle us all. In our practice, we often encounter the unexpected. As anesthesiologists, every day we encounter these. What do? We stop, ponder, and rethink. In the process, every case that rattles us becomes a learning opportunity. This evening, we are presenting 3 cases that rattled us, which we took as a rare learning experience. We paused, we pondered, and relearned, and would like to share what we learned and understood. To present these cases and take the discussion further, we have 3 young stars in the anesthesia horizon, and to guide them are lead consultants of the subspecialty anesthesia that manage the case. Briefly, the first case will be presented by Dr. Namita, who is a DNP resident, and with us, the presentation will be moderated by Dr. Antopol, who is in charge of neurosurgical anesthesia. The second topic, we have Dr. Deepak, who is a DNP resident, who will present, and the topic will be moderated by Dr. Vivek Menacheri, who is in charge of surgical intensive care. The third case is from our solid organ transplant anesthesia unit. The case will be presented by Dr. Jayashankar, guided by Dr. Shalini Ramakrishnan, who is in charge of transplant anesthesia. So without further delay, let me invite Dr. Antopol to take over and proceed with the case. Thank you.
Thank you, sir. Very good evening to all once again. As sir said, once in a while, we might come across a rare disorder in our clinical practice. Some can give you nightmares, and some might be even be last-minute surprises. Whether you like it or not, each one of us might be in such a situation one day. So some teach us new lessons, some remind us of old forgotten lessons. Each step you take can make the difference between success and failure. So being meticulous and sticking to your basics can save your day in the end. That's what we professionals do daily. So without wasting much time, I now invite Dr. Namida to present one such case we encountered recently.
Good evening to all. Going to the case, the stiff man, a nightmare. A 56-year-old female with intermittent muscle pain, rigidity since 10 years presented to the emergency with alleged history of slip and fall at home. She complained of pain in lower back and this was associated with lower limb weakness. The pain was of dull aching type, aggravated with movements, and she also complained of urinary incontinence and altered bowel habits. Her left lower limb weakness was progressive over the past 2 weeks. Her MRI revealed severe lumbar compression and canal stenosis, and she was posted for decompression, laminectomy, and pedicle screw fixation by the spine surgery team. Coming to the past history, she gives a history of port spine in 2008, which was treated with anti-tubercular drugs for 18 months. She also gives a history of severe back pain and lower limb pain as a part of lumbar tuberculosis with secondary lumbar compression syndrome with cauda equina as shown in the MRI. Her symptoms since 2011 was suggestive of stiff person syndrome and she was on regular follow-up in the neuromedicine department since March 2021. She is now on IV immunoglobulins 70 grams once in 3 weeks. She is allergic to morphine. Coming to the drug history, she is on tab diazepam, tab baclofen, IV immunoglobulin 70 grams infusion once in 3 weeks, tab pregabalin and tab Evion LC. On examination, general examination, she is conscious, oriented to time, place and person, moderately built and nourished, height of 159 centimeters, weight 59.2 kg, BMI of 23.4. Her pulse rate was 80 beats per minute, regular rhythm, regular volume, normal character, no vessel wall thickening, all peripheral pulsations felt equal, no radioradial or radiofemoral delay. Her BP was 130/80 m of Hg in right upper limb in the supine position, respiratory rate of 16 per minute, regular respiration. There was no pallor, jaundice, clubbing, cyanosis, lymphadenopathy or peripheral edema. Skin and hair appears to be normal. An airway examination, mouth opening was more than 3 fingers, Malambati grade 2, 1 finger can be insinuated in front of tragus, no restriction of neck movements, thyromental distance was more than 3 finger breadth. On central nervous system examination, higher mental functions were normal, cranial nerves were normal, motor system examination, bulk, there was no wasting or hypertrophy, tone was normal, no spasticity, no rigidity. On checking the power, her right lower limb was 4/5 power and left lower limb was 2/5 grade power. Ankle jerk and knee jerk was brisk and bilateral. Babinski sign was plantar bilateral. Sensory examination, sensory deficits from L2 to S1 level in the left lower limb. Gait was not assessed. Speech was normal. In the operation theatre, on rolling in the patient, we attached the monitors, ECG, NIBP, SpO2, temperature and entropy. Pre-medications, glycopyrrolate 0.2 mg, midazolam 1 mg, ondansetron 4 mg was given, fentanyl 100 microgram was given. She was induced with propofol. Mask ventilation was easy. Neuromuscular blocker used was atracurium 25 mg. Neuromuscular monitoring was done after induction. Trachea was intubated with 7.5 mm size endotracheal tube, Cormac-Lehane grade 1. Anesthesia was maintained using propofol infusion and dexmedetomidine infusion. After positioning in prone position, USG guided lumbar erectrospinal block was given using 40 ml of 0.25% bupivacaine. Tramadol 100 mg and diclofenac 75 mg IV was also given for postoperative analgesia. Surgery lasted around 4 hours with minimal blood loss. Entropy-guided titration of anesthetic infusions was done. Towards the end of surgery, infusions were tapered off. At the end of procedure, TOF ratio had recovered to 0.95. Patient was awake, obeying, breathing adequately, and she was extubated in the operation theatre itself. Post-operatively, patient was monitored in the surgical ICU. She was on fentanyl infusion post-operatively. Her oral medications were restarted and she was shifted to the ward on post-operative day 2. Now coming to the main part, that's a stiff person syndrome. It's a rare acquired neurological disorder which was first described by Morris and Boltman in 1956. The symptoms are progressive muscle stiffness and rigidity and repeated episodes of painful muscle spasm, which was precipitated by sudden noise, tactile stimuli, emotional stress. It is also known as Stiffman syndrome, Morris-Boltman syndrome. Incidence is 1 in 1 million. Females are more affected than males. Age group is 20 to 50 years. Pathogenesis is not known exactly. An autoimmune component to the pathogenesis is suggested. Association with type 1 diabetes mellitus and other autoimmune disorders, and the presence of autoantibodies targeting proteins associated with the GABA-related neural pathway. Impairment of the GABAergic pathways by autoantibodies and a reduction of brain GABA can lead to the clinical manifestations of stiffness, spasms, and phobias. Other associated conditions include thyroiditis, vitiligo, and pernicious anemia. Glutamic acid decarboxylase or GAD is an enzyme which is necessary for the production of GABA. GABA has an inhibitory input to the muscles, causing a muscle relaxant effect. Reduction in the GABA production upsets the balance of excitatory inputs in various areas of the brain, specifically the gamma motor neuron system, leading to continual motor neuron activity and spasms. There are 3 clinical subtypes of stiff person syndrome: classic stiff person syndrome, partial stiff person syndrome, and paraneoplastic, of which the most common type is classic stiff person syndrome. Coming to the laboratory findings, most routine lab tests doesn't show any abnormalities. General laboratory test, normal complete blood count, ESR, CRP, creatine kinase and aldolase levels are normal or slightly elevated. The anti-GAD antibodies 65 kilodalton isoform will be more than 1000 units per ml in 60 to 80% of patients with classic SPS. Oligoclonal banding in CSF and anti-GAD antibodies are positive in 15% of partial stiff person syndrome. Other autoantibodies like anti-thyroid, thyroid peroxidase, thyroglobulin, anti-gastric parietal antibodies can be detected. EMG will show a continuous motor activity which can be suppressed by intravenous diazepam, sleep, or general anesthesia. Diagnosis: there is no formally accepted criteria. Following features are to be considered for a diagnosis: stiffness in the axial and limb muscles resulting in impairment of ambulation, presence of superimposed episodic spasms that are precipitated by sudden movement, noise, or emotional upset, a positive therapeutic response to oral diazepam, or findings of continuous motor activity on the EMG that can be abolished by intravenous diazepam, and absence of other neurological disorders that may explain the clinical features. Treatment: the initial or symptomatic treatment is with benzodiazepine, diazepam 20 to 80 mg per day as divided oral doses, or clonazepam 1 to 3 mg. Resistant to initial symptomatic treatment, we can treat with baclofen orally 10 mg twice or thrice daily. Baclofen is a GABA receptor agonist. The maximum dose is 80 mg in a day. Severe disease or resistance to symptomatic therapies, we can go for IV immunoglobulins when the patient is not responsive or intolerant to benzodiazepine. Dose is 2 gram per kilogram in a treatment course over 2 to 3 infusions, each usually separated by 3 to 5 days. In patients who do not respond to initial IV immunoglobulin dose, a second round can be tried with 2 gram per kg given every 2 weeks for up to 4 doses. Patient failing this treatment should opt for another intervention. If there is a resistance to IV immunoglobulin as well, we can opt for B-cell depletion or plasma exchange. Anesthesia concerns: Regional anesthesia is considered to be safest, but the problem is potentially difficult, and this can induce spasms because of the pain during needle entry. Proper preoperative explanation to alleviate the fear and anxiety and adequate premedication can solve the problem. Coming to general anesthesia, postoperative muscle weakness requiring mechanical ventilation despite the appropriate reversal of muscle blockade is a concern. Volatile anesthetic agents can also potentiate hypotonia by their action on GABA-B receptors. Volatile anesthetics enhance the GABAergic input by extending the postsynaptic inhibitory currents when GABA is released. Baclofen, which is a GABA-B receptor agonist, can induce presynaptic GABAergic modification, which results in enhancement of the effect of volatile anesthetics on the GABA receptor. This can lead to postoperative hypotonia and delayed emergence. Appropriate temperature monitoring and regulation during surgery is important, as long-term baclofen therapy would impair the temperature perception and increases both threshold to warm and cold stimuli. Baclofen activates the receptors for GABA-B, which modulate the temperature perception. For induction of anesthesia, propofol is a safe choice. There have been reports on etomidate causing intraoperative myoclonus. Anti-GAD antibodies have no action at the neuromuscular junction, and in some studies, it is explained that neuromuscular junction was unlikely to be affected in stiff person syndrome. Continuous monitoring of the patient parameters such as TOF and BIS, which aid in keeping the dose of neuromuscular blockers and volatile agents or propofol to a minimum is recommended. Thank you.
That was a very lucid presentation from Dr. Namita. There are no questions that is typed in the chat box, but we have about 5 minutes for question and answer session. I will pass it on to Dr. Ando to lead the question and answer session if there are any queries.
So one thing asked was is there any restriction for the use of succinylcholine? So there are no clear guidelines regarding SPS, as it's a very rare disorder, but it has been used successfully in various case reports, and as such there is no contraindication for the use of succinylcholine. And another thing was is use of neuromuscular blockade mandatory. So these patients typically the symptom is stiffness. So some kind of muscle relaxant might be required for the initial intubation part. In this case also, we used atracurium for as the neuromuscular blocker for the intubation. That was only the initial dose, and it was not repeated.
Any more questions? Okay, we have one more query.
Another question was, is there any benefit of using atracurium over the zoccolonium? Okay, once I have no definite answer for that, but I have done only one case. There have been recommendations that you can use zoccolonium if you have Sugammadex available, so that you can reverse. But better to go for the short-acting agents whenever possible. So, regarding post-op management, the patient was extubated in the operation theatre. It was an uneventful procedure. We had given lumbar rectus spinal block for the post-op analgesia. She didn't have any symptoms, any hypotonia, any spasm in the post-op period. She was started on her own medications as soon as she could take orally. And for further post-op analgesia, she was given fentanyl infusion. And post-op period was uneventful.
I think if there are no more queries, we'll wind up the first case. Now we'll move on to the second case of the day. I would invite Dr. Deepak, our resident, and Dr. Vivek Manacheri, who is in charge of our surgical intensive care unit, for the second case. I would invite Dr. Vivek Manacheri to take over and proceed with the presentation. There is a minor technical glitch. We are sorry for the delay. It might take a couple of minutes.
Thank you, Sachin sir. A very good evening, one and all. Myself, Dr. Vivek T. Manacheri. I'll be moderating this session. I'll be moderating because I was the one fortunate to do this case in our hospital here. And firstly, let me thank the ISA and the organizers for giving this opportunity to present this case in front of this august audience. So, the case which I would like to discuss here is one which brought with it a unique set of challenges for us. So whenever we come across a case outside the operating room, especially in the remote location areas, we find a lot of challenges, and definitely it comes with the baggage. And then when you come to know it is a pediatric case, your heart starts beating faster. Then when you come to know that particular child is having a unique syndrome which is very rare, then your heart might even skip a beat. So without further delays and suspenses, I would like to request Dr. Deepak, our resident, to start with the case presentation, The Girl Who Forgets to Breathe. Over to you, Deepak.
Thank you, Vivek sir. Good evening, one and all, and thank you for giving me the opportunity to present this topic here today. So, without further ado, let's move on to the presentation. So let me start with a short case report. of a girl who forgets to breathe. So we have a 3-year-old female child weighing 15 kg who was the first child of a non-consanguineous marriage born out of IVF conception. Her mother had history of gestational diabetes mellitus and was on diet control since second trimester. Child was born by elective cesarean section term with a birth weight of 2.8 kg. Her parents was working as IT professionals and they were settled in Netherlands. She was developmentally normal till 2 years of age, following which there was a rapid onset of weight gain to 18 kg. At this point, their parents they consulted a dietitian, and through diet modification, there was a reduction of about 3 kgs. So after a few months, she had an episode of being rigid with eyes deviated to the left and severe respiratory distress, for which she was intubated and mechanically ventilated for 1 week in the pediatric ICU. Upon evaluation, she was found to have marked carbon dioxide retention, which eventually improved with mechanical ventilation. She was also found to have hyponatremia, low free T4 and low cortisol levels. EEG, echocardiography, USG abdomen and CT thorax were normal. MRI brain was also done, which did not show any specific changes, but details regarding the mode of anesthesia is not known. Polysomnography was done, which confirmed central apnea. She was later discharged and started on BiPAP at home during sleep. Further follow-up was done after the parents returned to India, and by this time she was around 3 years old, and she had also developed strabismus in the right eye and was also having difficulty in swallowing. Video fluoroscopy and esophageal manometry revealed severe esophageal dysmotility. A GE reflex scintigraphy study was also done, which showed grade 4 GERD. She was also having high blood pressure, for which she was started on tab enalapril. So in summary, we have a 3-year-old female child with rapid onset weight gain at 2 years of age and subsequently developed hypoventilation and respiratory distress requiring intubation and mechanical ventilation, who on further workup was found to have hyponatremia and endocrine anomalies like low free T4 and low cortisol levels. Polysomnography confirmed central apnea and she was started on BiPAP at home during sleep. Later she developed skin in right eye and was also having difficulty in swallowing. GI studies revealed esophageal dysmotility and GERD. She was also having high BP and was started on enalapril. So this child presented to the pediatric department of our hospital for further evaluation and management, and as a part of that, she was posted for MRI brain under anesthesia. So under evaluation, our pediatrics team arrived at the following differential diagnosis. This included congenital central hypoventilation syndrome, also known as Ondain's curse, obesity hypoventilation syndrome, also known as Pickwickian syndrome, Prader-Willi syndrome, MNGIE syndrome, which is mitochondrial neurogastrointestinal encephalomyopathy, Cushing syndrome, and ROHAD syndrome. But based on the clinical features, a provisional diagnosis of ROHAD syndrome was arrived at. So when such a child presents to us for MRI brain under anesthesia, it possesses certain challenges that are not only related to the ROHAD syndrome, but also because of the fact that we are stepping away from the comfort zone of our operating theatre to perform a non-operating room anesthesia, where we don't have the luxury of all the resources available in the OT. So coming to the anesthesia concerns in this patient, first let's start with the patient concerns. First of all, airway and respiration. So because of obesity and obstructive sleep apnea, this makes these patients high risk for difficult mask ventilation and intubation. They are also having reduced ventilatory response to carbon dioxide. They are also at increased risk of desaturation and respiratory failure due to central hypoventilation. And because of autonomic dysregulation, they may have a labile blood pressure. They can develop brady or tachyarrhythmias, They can have body temperature dysregulation, alteration in gastrointestinal motility, resulting in delay in gastric emptying and possible full stomach, altered perception of pain, altered sweating, and behavioral abnormalities. Because of hypothalamic dysfunction, they can have obesity, impaired water balance leading to hypo or hypernatremia, adrenal insufficiency, and hypothyroidism. And then there are the non-operating room anesthesia concerns, like anesthesia machine with minimal monitors, limited access to drugs and equipments, need for all equipments that is taken into the MRI suite to be MRI compatible, limited availability of trained staff. So these are the challenges that we were facing. And so now let's dive into how we manage this patient. Before the procedure, we counseled the mother about the risk of hyperventilation, aspiration, and the need for post-procedure ventilator support. A high-risk consent was obtained. Physical examination and airway assessment was done. We confirmed the NBO status, and intravenous access was obtained. Preoperative investigations, including serum electrolytes and ABG, was reviewed. We ensured that a morning dose of hydrocortisone was given. So, our anesthetic plan for this patient was general anesthesia with controlled ventilation. We decided to intubate the child at the pediatric ICU and then shift her to the MRI suite. So we anticipated difficult mask ventilation and intubation. We were prepared with oral airway and IGEL. We began with pre-oxygenating with BiPAP, IV atropine 0.1 mg, midazolam 2 mg, ketamine 30 mg, and ondansetron 1.5 mg were given. We avoided long-acting opioids. There was difficulty in ventilation by the pediatrics team. We helped out by ramping and providing shoulder support, following which ventilation improved. And once we made sure that we could ventilate, atracurium 7.5 mg was given. We made 2 attempts at intubation, and finally we succeeded intubating with 4.5 mm cuffed endotracheal tube, which was fixed at 12 centimeter. After intubating, confirming by auscultation, and securing the tube, we shifted the child to the MRI suite by ventilating with the pediatric ambu. While shifting, we were careful to prevent accidental dislodgement of the endotracheal tube, Ryle's tube, and IV line. And once inside the MRI suite, for maintenance, we used oxygen air mixture in about 2 liters per minute. We kept sevoflurane at 2%. The procedure lasted for about 2 hours, and a top-up of ketamine and atracurium was given. Our ventilator settings were: we put the ventilator in VCV mode, tidal volume at 120 ml, respirator rate of 30 per minute, PEEP of 4 cm H2, and the peak pressure was around 21 cm H2. So the procedure was uneventful, and after which the child was shifted back to the pediatric ICU. Our plan was, we planned for elective ventilation overnight, and for sedation, propofol infusion was kept. Next day, she was weaned off the ventilator in CPAP mode, and she was later extubated. But later she developed hypoventilation and desaturation episodes, and therefore BiPAP was reinstated. So, in short, we avoided IV induction and opioid agents that depress ventilation, and we were prepared and vigilant with airway equipments ready. So now let's have a look at ROHAD in little bit more detail. So ROHAD, it is an acronym which stands for Rapid Onset Obesity, Hypothalamic Dysfunction, Hypoventilation and Autonomic Dysregulation. It is a rare disorder of respiratory control and ANS regulation with endocrine system abnormalities. The acronym describes the typical sequence in which the symptoms appear in majority of the children, which was true in the case of this child also. It was first described in 1965, and since that time at least 100 children have been reported in literature or identified with this disorder. Then coming to the signs and symptoms, the abnormalities, they usually manifest between 1.5 to 7 years of age, which was the case with this child also, where the symptoms start manifesting at 2 years of age. The first sign is rapid onset weight gain with associated hyperphagia. This rapid onset obesity is due to hypothalamic dysfunction. Apart from that, there are also other hypothalamic and endocrine anomalies, which include the inability to maintain normal water balance, resulting in abnormally high or low serum sodium levels, increased prolactin levels, decreased thyroid hormones, early or late onset puberty, decreased cortisol levels. You can also have breathing abnormalities like obstructive sleep apnea and alveolar hypoventilation, which is the most life-threatening feature of ROHAD. Because of autonomic dysregulation, there can be bradycardia, temperature dysregulation, which can be hyper or hypothermia, although hypothermia is more common, altered intestinal motility resulting in constipation or diarrhea, eye abnormalities resulting in altered pupillary response to light and strabismus, decreased pain sensation and altered sweating. There can be anatomic malformations of the anus also that include neural crest tumors like ganglioneuromas and ganglioneuroblastomas. These are mostly found in the chest and abdomen but can occur anywhere along the sympathetic chain. Now ROHAD, along with neural crest tumor, it is actually placed in a subcategory called ROHAD net, and the presence of neural crest tumor is not a requisite to make a diagnosis of ROHAD. The other features include behavioral and mood disorders, developmental disorder and seizures. So the diagnosis of ROHAD is purely based on clinical features. So it is based on a clinical criteria which includes rapid onset obesity and alveolar hypoventilation during sleep starting after the age of 1.5 years, evidence of hypothalamic dysfunction as defined by at least one of the following, which includes rapid onset obesity, hyperprolactinemia, central hypothyroidism, disordered water balance, failed growth hormone stimulation test, corticotrophin deficiency and altered onset of puberty which may be delayed or precocious, and the absence of CCHS related FOXP2B mutation to genetically distinguish ROHAD from CCHS. And actually this is how our pediatrics team arrived at a provisional diagnosis of ROHAD. They did a gene study and our child was actually negative for FOXP2B mutation, which helped to rule out other DDs, especially the CCHS, that is congenital central hypoventilation syndrome. Now, a short follow-up of the case. So, after all these things, she was discharged, and after 1 month, she was again brought to the ER in an unresponsive state where CPR was given and ROSC was attained. She was intubated and mechanically ventilated. She was eventually weaned off ventilator, but she kept developing recurrent apnea episodes, and she had to be re-intubated. There were also several episodes of bilious vomiting. The parents were counseled regarding the need for tracheostomy, gastrostomy and fundoplication, to which they consented. So this is how we managed the tracheostomy, gastrostomy and fundoplication. Our plan of anesthesia was general anesthesia with controlled ventilation, and she was actually already intubated because she was having recurrent apnea episodes. She was intubated with 4.5 millimeter cuff tube and fixed at 12 centimeter. Central venous access was obtained through right femoral vein. Riles tubes was in situ. She was shifted from PICU to OT with the E2 tube connected to a JR circuit, and she was breathing spontaneously. So at OT, before induction, she was covered with a bear hugger to prevent hypothermia. Monitoring devices were connected. For monitoring, we use continuous ECG, NIBP, pulse oximetry, ETCO2, temperature monitoring, input-output monitoring, and blood sugar monitoring. Before induction, glycopyrrolate 0.2 mg, fentanyl 20 mcg, hydrocortisone 50 mg, and atracurium 7.5 mg IV was given. Inhalational induction, induction was through inhalational induction with sevoflurane 5% and oxygen. Anesthesia was maintained with sevoflurane 2%. Our ventilator settings was SIMV, PCV, VG mode, tidal volume of 120 ml, respiratory rate of 30 per minute, and PEEP of 4 cm H2O. For analgesia, we kept fentanyl infusion at 15 mcg per hour, and paracetamol 220 mg IV was given. Hydrocortisone infusion was also kept at 2 mg per hour. The intraoperative period was uneventful, and she was later shifted to the pediatric ICU for elective ventilation, and was later weaned to BiPAP uneventfully. Thank you all.
Thank you, Deepak. That was a very nice and detailed description about the case. So firstly, when we all would have heard about this terminology ROHAD, I think all of us would have, or many of us would have started Googling it, what that would be. Now we really know what exactly ROHAD means, and as Deepak had told, it is an acronym, and it's actually a life-threatening disease because it affects the autonomic nervous system, the endocrine system, and many other systems, and you don't have a control over the breathing and the heart rate. So, and I also wanted to tell you this is a rare disease. It was first reported in 1965, if I'm not wrong, and till date only 158 cases have been documented worldwide. And the etiology, pathophysiology, the prevention of this disease, and the exact treatment modalities are all unknown, to be honest. So, with this patient, our anesthesia team worked in coordination with the primary treating team, that was the pediatric neuro department, along with the pediatric intensive care unit, so that that made our job easier and that benefited the child on the long run. So my message to you, especially to the young residents, would be always to work in coordination with the primary treating team and follow safe anesthetic practices, especially in such cases, to bring out a better outcome. Thank you.
One question, Vivek. Another thing, one nightmare is enough, and you underwent this nightmare with this child, I think, thrice.
Yeah.
You would be the best person to answer queries regarding this. Now, one very pertinent question Jaya Madam asked was, why was propofol not used? Were there any particular reason why you didn't use propofol for induction?
I chose ketamine over propofol because I was not very sure about the autonomic disturbances that might occur, and I didn't want a cardiac depression, a hypotension or a bradycardia happening while I was inducing the child. So probably I can say that is the main reason why I chose ketamine over propofol.
And given the history of the child in our ICU, the child already had autonomic disturbance and bradycardia episodes.
Yes.
And we are very fortunate to have Nair sir here in midst of us, because he would be the best person to answer this. This was basically treated by his department when he was at Rajagiri. Nair sir, are you still there?
Yeah.
Yeah, sir, can you throw more light into this topic, Rohhad?
See, I can only tell you something. It's a very, very rare condition. Am I audible?
Yes, sir. Very much.
Yeah. There are lots of similarities, especially phenotype and clinical features between Prader-Willi and ROHADs, because most of the pediatricians are more aware of Prader-Willi syndrome. So probably that is the first thing which comes to the mind. And only with experience, probably one may think of ROHAD. Now, the major difference is that generally Prader-Willi children, they manifest during the first year, during infancy. In ROHAD, they are generally asymptomatic during the first year. They develop these symptoms probably, generally after the first year. Otherwise, it's a very, very rare case, and compliments for the people to have picked it up. And I don't know whether you are going for the, genome study. That is the only way it can be proved, actually.
I think we did that FOX2B mutation gene study, and that came as negative. That's how we ruled out CCHS from ROHAD.
So then we are not at. If that has come negative, probably then I don't know what is the diagnosis in that case.
From the literature, what I understood is if we can rule out that FOX2B gene mutation, you can rule out the other causes, and you can maybe end up with the diagnostic criteria. I think you can end up with the diagnosis as ROHAD.
Probably. See, I have not so much knowledgeable about this, because most of the pediatrics, we are more aware of Prader-Willi, which we see more often, being more common.
To add
And
upon,
this is a very, 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 very rare condition, Rohhad.
We are very thankful, sir, because like we found a very robust pediatric department. Now it has grown up like anything, and we are getting. And we work in very close association with our technology, uh, Indian.
Have you published it? Because very few mentioned literature about this.
This
I think you should publish the case report.
in the processor, and more than that, in anesthesia, rare case, we were also
Hello.
since our anesthetic concerns coming back to um, uh, can others can others be muted, please? Okay. When it comes to concerns in anesthesia, even we were a little perplexed as to how our routine anesthetic drugs, including the inhalation agents, would behave. So we were very careful when we dealt with this child in the first instance, and the second and third time we were more confident. So is there any particular reason why we didn't go for a inhalational induction? We ourselves were not sure. We were trying out different modalities because there are no available literature or any guidelines regarding how to manage these kind of children. One side it is difficult airway, the other side it is autonomic disturbance, and the third side it is hypoventilation, central hypoventilation. So that is a recipe for disaster in any case. So I think that will bring us to the end of our second case, and we have one more case discussion left. That will be a case from our solid organ transplant anesthesia unit, which will be presented by Dr. Jayashankar, and it will be moderated by Dr. Shalini Ramakrishnan, who is in charge of transplant anesthesia. I would welcome Dr. Shalini to proceed with this discussion further.
Thank you, Dr. Sachin, for that introduction. A very good evening to all of you. My sincere gratitude to ISA Kerala and Kochi's City chapter for giving us this opportunity. Liver transplant in Rajagiri is a child who is just learning to walk. We have just completed our 8th liver transplant recently. We had our share of teething problems, as everyone. We had our share of unexpected complications. Our liver transplant team, though nascent, were steadfast and passionate, and ultimately we were able to tide over every crisis that came in our way. With each complex situation, we were getting bolder, more confident, but equally aware of the challenges ahead. Then came this patient, and a challenge for us as a bolt from the blue. This patient was the 4th liver transplant recipient in our program. We chose this case for its rarity, but more than that, we need valuable inputs from our senior transplant anesthesiologist in this forum. Every case is a learning opportunity for us. With this, I invite Dr. Jayashankar to present this case.
Thank you, Shalini Madam. Hello, good evening all. We have come to a third rattle of the day, and I will be presenting an exotic complication in a liver transplant recipient. A recipient is a 42-year-old male bus driver from Thrissur who presented to the hospital 5 months back with progressive abdominal distension, a generalized edema, jaundice, and coagulopathy. as a known case of chronic liver disease with portal hypertension of ethanolic etiology. He had no other comorbidities. He was a gentleman with a BMI of 25. His child score was 10 and categorized as C, and MELD score and MELD sodium was 32 and 33. His labs were in acceptable limits for transplant. A donor was his wife, a 34-year-old yoga instructor. During the pre-op workup, labs and his liver biopsy was within acceptable limits.
Excuse me, can I interrupt? Can you share the slides because we can't see anything on the slide share?
Is it visible now, madam?
No.
Yeah, yes.
Yes, thank you.
So our patient was a recipient was a 42-year-old male bus driver from Thrissur who presented to the hospital 5 months back with progressive abdominal distension, generalized edema, jaundice, and coagulopathy. Is a known case of CLD with portal hypertension, ethanolic etiology with no other known comorbidities. His BMI was 25. His child score was 10. MELD and MELD sodium was 32 and 33. His labs were within acceptable limits for transplant. A donor was his wife, a 34-year-old yoga instructor. The pre-op workup was insignificant. It was all labs and biopsy, everything was within normal limits. Coming to the perioperative details, lab donor liver transplant was done on 19th of February this year. It was a 10-hour long surgery. The graft taken being the right lobe without middle hepatic vein. The procedure went uneventful, and we shifted the patient late in the evening to the transplant ICU with minimal supports, and ABG and labs were in acceptable limits. And the next day, we extubated him and tapered off the supports. And routine Doppler ultrasounds, along with the lab reports and the clinical assessment, showed the allograft function was good. Post-op day 2, he was mobilized out of bed. As you can see, he was giving us a thumbs up from the chair. And we started him on immunosuppressants to start up with methylprednisolone as per our protocol. Blood and urine culture, which was sent in drop, came as negative. These were the labs in post-op day 2. He gradually escalated the immunosuppressants, and by post-op day 7, he was on tacrolimus, mycophenolate mofetil, and Vicelon. We started him on valganciclovir and fluconazole according to our transplant protocol. And by then, all lines were out, including a central line, HD catheter, and Foley's. He opened his bowels and started to have Urli. And he was clinically well, and all the labs were within acceptable limits. We noticed a rise in C-reactive protein and total count by post-op day 11, and for which an ultrasound abdomen was done, which showed a collection there. And to get a clearer picture, we did a CT, which revealed a collection near the liver cut surface. He was still afebrile. His vitals were within normal limits. So we decided to, we started him on meropenem and teicoplanin. And other than the total count and the C-reactive protein, rest of the labs were almost the same as before. And the next day he started developing, he was complaining of malaise. He was still febrile. A pigtail catheter was inserted and drained the collection, which was bilious. And that was kept there, and the drain output was around 200 to 300 ml per day for some more days later on. His vitals were stable, and his total count and C-reactive protein came down to near normal. And by post-op day 17, he was clinically well, and in view of the persistent biliary leak with significant drain output, we planned on an ERCP for him. He was already on day 6 of meropenem and teicoplanin. So we did the procedure the next day. ERC showed a minimal dilatation with leak in the posterior duct, for which the stenting was done. His vitals were within normal limits. The procedure was done under general anesthesia, and in the perioperative period the vitals were normal, and we shifted him back to the HDU. The labs were also, as you can see, they were near normal. The next day he started developing fever, 101 degree Fahrenheit, and other than the tachycardia, there were no other specific symptoms. Like the rest of the vitals were within normal limits. Blood and urine, which was sent at that time when he developed fever. And the next day the fever was persisting even after antipyretics and tepid sponging. Blood and urine cultures, the professional reported as sterile. So we decided to de-escalate the immunosuppressants except the steroids. So we were looking for a cause, whether the stent caused this or is it an infection which caused the fever. So to cover our organism, we started on polymyxin B, and we ensured the stent position by repeat CT. By then the drain bile culture grew gram-negative bacilli. As you can see, the CRP raised to 36. And we were looking at sepsis or not. That's what we were all confused, and we noticed a drastic progressive drop in hemoglobin and platelet from post-op day 19 to 22nd, which was hemoglobin was 8.4 on post-op day 19, which became 7.3 on day 21, which further reduced later on. Platelet count was 140 at post-op day 19, which became 110 and 75. So there we decided to wait for the culture report, and the next day drain bile culture reported multi-drug resistant Klebsiella pneumoniae. His fever was still persisting, and it worsened. It became 102, 103 degrees. And then we had a discussion with the infection control officer and the intensivist in our institute, and we decided to start him, add him on ceftazidime and avibactam. His vitals were still within normal limits, and the sensorium was normal, and LFT was also normal. The next day, the fever still persisting. We decided to stop fluconazole and start him to get a complete antifungal cover. To start him on an echinocandin and idursulfungin. And in view of the persistent anemia, we decided to stop valganciclovir and transfuse 2 units of irradiated packed red blood cells. But the next day, along with the fever, he developed 2 to 3 episodes of loose stools, and he developed hypotension as well. CRP was raised, and rest of the parameters were somewhat similar, other than the anemia and slight raise in transaminase enzymes. In view of the temporal correlation of fever with the ERCP, the stent was removed, and to maintain mean arterial pressure, we decided to start him on low dose of noradrenaline. The next day, he developed 1 episode of melena. Hemoglobin dropped to 6.1. He had tachycardia and hypotension. Along with that, even though he was making adequate amount of urine output, it was dark colored. It could be hemoglobinuria also. So lactates in the ABG was 6 in the morning that day and became 9.8, and there was severe hypoglycemia as well. Stool culture grew Clostridium difficile by then, so for which we started him on oral vancomycin and metronidazole. The patient became slightly drowsy and he was tachypneic. The ABG showed a metabolic acidosis with respiratory compensation. So over the few days, fever was waxing and waning, but never touched the baseline. So at this point, we were at a diagnostic dilemma, for which a multidisciplinary board meeting was called for, and we decided to cover with fosfomycin and IV amphotericin B. And even COVID-19 was ruled out by doing an RT-PCR. And as a part of a hemolysis workup, we sent a peripheral smear. The peripheral smear showed this. We were all shocked to see this. RBCs, we can see the inside RBC cytoplasm, we can see ring forms and acol forms, which was suggestive, the morphology suggestive of malaria infection with Plasmodium falciparum. It was in post-op day 25. So the parasitemic index was 14 to 16%. And non-immune person, more than 2% is considered as severe, and then semi-immune individuals with more than 5% of parasitemic index is considered as severe malaria. By then the ABG showed a severe metabolic acidosis with lactates of more than 15, severe hypoglycemia, and he became further drowsy but arousable. Transaminases raised a bit, and he started developing coagulopathy, and his renal functions are also slightly worsening. All immunosuppressants were withheld except the steroids, and as per the treatment guidelines, we started him on artesunate at 2.4 milligrams per kilogram at 0, 12, 24, then once daily for 6 days regimen. That was initiated. And to maintain the mean arterial pressures, we had to start him on noradrenaline and vasopressin supports. And by then he clinically deteriorated, and considering the metabolic acidosis and general condition of the patient, we decided to electively intubate him and start him on continuous renal replacement therapy. His transaminases further increased almost to 240 and 150, and coagulopathy also set in, and APDD was 68, INR was 4, and creat was also slightly worsened, and anemia still persists. The next day morning, he started developing peripheral ischemic changes, which could be due to DIC or inotropic infusions or vasopressin infusion, which we have, or it could be due to sequestration of parasitized RBCs, which get clogged in the microvasculature, which further causes the ischemia. Despite the 3 doses of artesunate, his parasitic index was 16 to 18%. And there was a tenfold increase in transaminases enzymes. CRP was 100. So INR also worsened. So, and the urine output also progressively decreased. He was going in for a multi-system involvement. Again, a multidisciplinary board meeting was called for, and we decided to do an exchange transfusion, which was started on post-op day 26. And we did it for 4 hours, followed by continuous renal replacement therapy with Oxidus filter for 24 hours. These were the vitals post-transfusion when he was on CRRT. This was maintained with inotropic and vasopressins, noradrenaline and vasopressin. His sensorium was a little drowsy then. Transaminases enzymes came into 10,000s. And the next day, Doppler showed increased hepatic heterogeneity and periportal cuffing. As per our radiologist, it was suggestive of hepatitis. Then parasitic index was 2 to 4%. And he had a series of atrial fibrillation, for which cardioversion was done. And by then, his renals had a complete shutdown. Peripheral ischemia worsened, and he was started on phenylephrine infusion to maintain a bare minimum blood pressure. And even after a time frame of around 6 hours, his transaminases almost doubled, came to 24,000 and 6,000. His iron coagulopathy also worsened. So at this point, we felt that it's a point of no return. So we explained a grave prognosis to the bystanders. The next day, on post-op day 25, Doppler showed a hepatic artery thrombosis, and we decided not to escalate treatment further. He had a cardiac arrest and succumbed to his illness on 19th of March, that 1 month after surgery at 1:45 p.m. Never forget the parasite. more than 200 million new cases of malaria, and more than 4 lakh deaths were estimated globally in 2015. And even though infections continue to be the commonest cause of post-transplantation morbidity, malaria, a protozoal infection, is extremely rare and has been rarely reported in literature, even in endemic. Cases reported after solid organ transplants, most were reported with renal transplants. Only 11 cases were reported post liver transplant patients globally, with the probable cause of malarial infection could be a graft or through blood or blood product transfusion. 6 of which were with Plasmodium vivax, 4 with Plasmodium falciparum, and 1 of it was mixed infection. Out of these 11 cases, 2 were from India, which were reported in 2009 and 2017, both from New Delhi. In the reported cases of malaria infection associated with transplants, the source of infection has not always been possible to define, and the probable sources of infection being a donor-derived infection, or a reactivation of a previous infection, or a primary or de novo post-transplant infection. A donor-derived infection could be from an infected organ or infected blood or blood products, and RBCs within the transplanted organ which transmits the disease. A reactivation of a previous infection in the form of a dormant hypnocyte in the liver, or a recrudescence of a persistent parasite in blood. Donor deferral policies. We don't have there are no uniform recommendations for donor deferral in solid organ transplantations with respect to malaria, and for all the potential donors who have had active infection should be deferred from donation until diagnosis and treatment. And once they are recovered, they should follow for local guidelines for donation. And those with a history of Plasmodium malariae infection, they should be permanently deferred from donation, because the Plasmodium malariae infection is characterized as a benign disease in the general population, and though they usually present with a very low grade parasitemia, which is difficult to detect, and moreover the incubation period and the relapse time frame and all these variables were not clearly defined for Plasmodium malariae. So unfortunately in India we don't have a donor deferral guideline with respect to malaria in solid organ transplants. US guidelines requires a 1-year deferral for travelers and a 3-year deferral for residents from endemic area or those who have had a previous infection. And European guidelines requires a 4-month deferral for those who are at epidemiological risk, but a negative serological or molecular screening, and a 3-year deferral for those who have had infection in the absence of a negative screening test. The rationale behind the 3-year deferral would be that the low-grade parasitemia would either become symptomatic by 3 years, or in the absence of a reinfection that will get resolved. The history we didn't have. Our patient gave a history of traveling to Mangalore, an endemic area, 6 months back. He had also visited a relative a few months back who had come from Tanzania, an endemic area where 96% of the cases reported there in Tanzania was from Plasmodium falciparum. He didn't give these histories when we did the workup. He gave it after the diagnosis. So when we look back, So when we look back, routine screening is not done for screening and evaluation for malaria is not been done for a transplant patient, but done for all blood donors. The screening for blood donors is a proper evaluation in the form of a questionnaire, and antigen rapid detection test was done, is usually done here in our institute. Even though the signs and symptoms point towards during a severe illness pointed towards a diagnosis, we had many confounding factors which delayed the diagnosis, and the surgical stress or immunosuppression might have resulted in a flare-up of illness. It could have been a reactivation of an infection, previous infection, or it could be a de novo infection, and the patient was in his incubation period during the surgery, or it could have been transmitted through transfusions. Even though we use irradiated blood, he might have had it before. So even though there were signs of symptoms pointed towards diagnosis, we never suspected malaria. He had a severe febrile illness during the period, and we couldn't find the exact cause. And by then, we should have had suspected malaria then. The take home is that we present this case for its rarity, and being surrounded by malaria endemic areas with a constant exchange of people between the loose boundaries, we recommend malaria risk evaluation and screening should be included as a transplant workup in the transplant workup for both recipient and donor as a routine. And even though we are in non-endemic area, in case of severe illness, febrile illness without definitive cause, malaria should be considered as a differential. These are my references. The last two were the cases reported from India.
Thank you, Jaishankar, for that. Right, you took us that roller coaster ride. You took us with you, and this case was indeed rare, and it was again an eye-opener to how we choose our patients. And before we move on to question and answer session, I would like to give a big thanks to the sponsors of today's evening, Themis Medicare, for helping us and supporting us with this academic program. Thank you so much. Now, Dr. Shalini, we are concentrating so much on how we choose our patients, and even the take-home message was based on that. Do you think an early diagnosis in this case would have made any difference in the outcome?
Yeah. Yes, Dr. Sachin George. First, we missed our patient's history. He is a driver. He had traveled to Mangalore and stayed there for 1.5 to 2 months. And when he developed a fever on 19th post-operative day, we picked up the parasite on day 25. So there was a delay of 5 to 6 days to pick up the parasite, because we were misguided by so many confounding factors like MDR Klebsiella from the bile, then Clostridium difficile from the stool, and ultimately the patient was going to a multi-organ failure picture. We were suspecting sepsis, so we had a definitive delay in the diagnosis of malaria. If we picked up the parasite in the early period, we must have served the patient. By the time we picked up the parasite index was 16 to 18%. When the parasite index is more than 10%, chances of complicated malaria is very high. So I think if we had an early diagnosis, we could have served the patient.
Okay, and one more doubt that can creep up in everyone's mind is why exchange transfusion here?
As I told, when we diagnosed, we had a parasite index of 16 to 18%. In spite of starting treatment with artesunate, the parasite index was very high, and the detected organism was falciparum, which may lead to a complicated malaria picture any time, especially in an immunosuppressed patient. We chose exchange transfusion because we had no other option that time.
Sachin, can I say something?
Yes, sir. Yes, sir.
See, this is just a interesting thing. It's a very interesting case. When we were young consultants, we were told that malaria can mimic anything other than pregnancy and motor vehicle accidents. I think later on that motor vehicle accident was removed because a person could get a malarial paroxysm while driving and he can meet with an accident. So I think that situation is going to slowly come back again. In India, I would like to have tuberculosis also. Whenever you are in doubt about anything, consider malaria and tuberculosis in our country. You will never be a loser. That's all.
Well, that point is noted. That was one of our take-home. That was the most important take-home message. But Sita Madam pointed out that we are a country with a lot of endemic diseases. Is it really possible to be choosy when it comes to these kind of diseases in a country, in a tropical country like us? If Lakshmi Madam and other senior transplant anesthetists in this forum, we would like to hear from them regarding this.
Sachin, I didn't get your question.
Ma'am, is it really worth it? See, because endemic.
Yeah, so it's malaria today, it will be dengue tomorrow. I think it just hits you sometime. You need to be vigilant. I don't think any of us can say categorically that these are all the tests that you will do. You'll still miss it, and it catches you by surprise. So I'm sure you would be saying malaria, malaria, malaria for the next few months, but that's going to go when you have a dengue in a recipient, and it happens all the time. So I just think more awareness and perhaps keeping your mind open for an exotic thing. I haven't been looking after the ICU the last 5 years. So, and I truly don't recall having malaria in our recipients, although I do remember dengue and some tropical diseases. So that's
See, one more thing, Sachin. I'm very happy to see a slide with ring forms, because I'm sure many of the doctors, they hardly get to see a slide. They already go for the antigen test. And I've seen it in the exams also. You ask them to identify a malarial parasite. They're totally at loss because they say we have never seen one. Our hospital, we only do the antigen test and we treat as per this.
Sir, in this case, we kept the advancement a little on our bayside. The diagnosis was clinched with the peripheral smear.
Yeah.
And to confirm the is it possible to mute? Okay. So in our case, sir, it was going back to olden times when diagnosis was clinched with the good old peripheral smear, and we confirmed it with more advanced techniques. I see Dr. Anindita and Dr. Nagesh here. We would like to acknowledge their great inputs in managing cases. Our initial cases. A big thanks to you from
Dr. Anindita and Dr. Nagesh for guiding us, for supporting us.
Thank you so much. Thank you so much. Yeah.
I think we'll wind up the clinical presentations of today. Dr. Shalu Madam will wind up the clinical discussions now. I'll hand it over to Shalu Madam for further proceedings. Thank you so much. And before we leave, I would like to say thanks to the entire anesthesia department. If all of you can join together, and there were few Dr. Manshad, Dr. George behind the curtains who were busy with the keypads and the mouses and the remote control for the video cam. They were all busy, and a bigger team who are managing cases in our theaters. Cases are still running, including a thoracotomy with one lung ventilation. So we could sit here because others are toiling for us in the theater. Thank you, everyone in the department. Thank you so much.
Sachin, you have lots of pictures on your backbone. Plenty of pictures.
That's what Rajagiri is all about, sir.
Great. I'm missing actually over there.
Thank you so much for coming, sir. And
thank you, Sachin.
Thank you, the Rajagiri team, for a wonderful academic session. I would like to thank the team, the chairperson and HOD, Dr. Sachin, and the co-chairs, Dr. Anto, Dr. Vivek Menancheri, Dr. Shalini, and also those who made wonderful presentations, Dr. Namita, Dr. Deepak, and Jay Shankar. Thank you so much. It was a wonderful presentation, and it was followed by active discussion. Thank you so much. Now we move on to vote of thanks. Over to Prema for vote of thanks. Prema.
Thank you, madam. So we have come to the end of an interesting academic session. And on behalf of ISA Cochin, I would like to thank Dr. Sachin George, HOD Rajagiri, for organizing this session, which included those rare troubleshooter cases. Special thanks to the moderators, Dr. Anto Paul, Dr. Vivek, and Dr. Shalini, and the speakers of the evening, Dr. Namita, Dr. Deepak, and Dr. Jay Shankar. All the presentations were very crisp and clear, and the discussions which followed were very informative. Congrats, Team Rajagiri. Our sincere gratitude to ISA State President Dr. Abdul Nasser and Dr. Binil Isaac for providing this platform for academic program. Thank you, Dr. Shalu Madam, City Branch President, for all that encouragement and support. I sincerely thank all my dear senior colleagues and postgraduates for participating with such enthusiasm. Special thanks to Themis Group for their support for this academic program. Once again, thanks a lot. Congrats, Team Rajagiri. Good night.
I would like to add thanks to General MNG Nair, who has given a lot of support to the team. He was the director of Rajagiri, and I think he made a presence here. And also, we felt his presence also. We should specifically thank him also. Thank you.
Yes, sir. Special thanks to Dr. MNG Nair as well. Thank you. Thanks a lot, sir.
Thank you, Prema. We'll wind up the session. Thank you.
Okay.